Good afternoon, everyone. Thank you very much for joining us here today at Healthmonics as we are delivering our latest in our webinar series. Today, we'll be talking about the crucial role of MIPS cost category and strategies for your success. I am joined here today by none other than our CEO and President, Lauren Patrick, and our MIPS Cost Analytics product owner, Daniel Patrick. Hi, Lauren and Daniel.
Hi, Mike.
Uh, hey, Daniel. Okay, a couple things before I hand it over to them for the call here. Uh, we do have the ability in the system for you to download the handouts. The handouts will be available during this presentation as well as through an email that I will send out later this afternoon. You do also have the ability to ask questions. We have a very thorough presentation today, but if there is time to answer some questions at the end, Lauren and Daniel will be happy to do so. I know the widget looks a little bit different right now as they've made some changes, but we'll get those screens up for next time. So without further ado, I am going to turn it over to Lauren and Daniel.
Good afternoon. Well, afternoon here on the East Coast. For the rest of you, it's probably still morning. Um, so today we want to talk about the cost category. We know that this is new, we know that this is different, and we know that there's some challenges associated with it. So our hope today is to help you understand a little bit better what the cost category is within the MIPS program and how you navigate it, how you can understand it, and then think about how you might be able to maximize your performance as you move forward, as we know that scoring well in MIPS is a significant advantage and goal for many people. So I'm going to start with understanding the significance of the cost category. As we looked at 2022, we saw clinicians start to see cost scores again within their MIPS Pro total score. The reason was when MIPS was started back in 2018, the legislation said that eventually being 2022, the cost category had to have equal weight with the quality performance category. CMS's rationale was that the cost of, we can get infinite quality of care if we spend enough money. So what they really want to do is balance cost and quality. We know that this is an imperfect world, and we know that these measures have a lot of imperfections in them, but we have gotten to the point where they are equal weight, and it's intended to assess performance among clinicians basically by comparing clinicians in terms of episodes of care, and it's scored without clinician involvement. So this is a challenge because many people say it's like you're taking a test you don't know you're taking. You're ill prepared for this test, and you don't know how you did on the test at all until 4 months after it's completed. Next slide, Mike. So why focus on cost performance? You can influence your score. While clinicians don't personally determine the price of individual services, a service has, in most cases, what we call a standardized allowed amount, and that is influenced by a lot of other factors. We're really looking at the cost of an episode of care, and clinicians can influence that based on where services are done, how services are done, what preventative services are done, etc. So that's why focus is important, because there are things that can be done to impact that cost. You can influence the types of service. You can ensure that patients are receiving the right services at the right time, based on specialties, based on knowledge, based on knowing your patients. You can look at making sure that your patients are appropriately documented. And you can also influence your score by choosing the right MIPS reporting strategy. So we're going to talk a little bit about both of these today. When you're in the MIPS program, there are now 5 different options for reporting. Despite the fact that CMS says they're trying to make this easier and simpler for everyone, the options are multiplying. Once you find an option, perhaps it is simpler, but getting to your option can be quite challenging. We help a lot of folks here at HealthMonix figure out their best strategy or strategies to report. But you can report as an individual, you can report as a group. There are virtual groups that can be set up. Very, very few participants in MIPS actually are using that option. You can report as an APM entity. For example, if you're in an ACO, an MSSP program, or other advanced payment models. And you can also, as of 2023, report as a subgroup. And we'll talk about these a little bit as we go forward. Next slide. So when you're in most of these reporting options, you're going to see that the cost score starting in 2022 is 30% of your overall MIPS score. That's quite a chunk, and it's quite a chunk considering there really was no ramp up. Because of COVID, the cost scoring could not be done well during the prior few years, and CMS every year just reweighted it out. But because of the mandate from the macro program, from the legislation, cost is now at a full 30%. So it is quite challenging, and you do have to pay attention to it if you're paying attention to your MIPS score in general. If you're an APM, though, the cost score is not part of your score. So you might think of, actually, some folks think this is a incentive to move out of MIPS into some advanced payment programs, but that is one way to negate the impact of the cost score. In 2022, many folks could still use the EUC to get cost reweighted. However, this is no longer an option. And in 2024, everybody must participate and everyone will receive a cost score if it's applicable to them and the reporting mechanism that they choose. When we looked at, so we have the option to dig into some of our clinicians' cost scores. And when we looked at them, we looked at about 1,000 final scores for 2022. And what we saw was the following distribution. Now, I want to note here, I want to call out that there's a big number in the 0 to 3 category. So that we had a lot of participants that had no points, but part of that was because they could choose to reweight it. And so it did go to 0. But you'll see that the majority of the scores are 15 to 18 points or under. So we really want to look at how do we impact that? How do we move that up? Because you're losing those points on your overall score. The cost category is spread out from 0 points to 30 points. CMS really is trying to make it across the board, so it's hard to get up to that 30 points. Let's look at the next slide, and I think I've shown an example there. Right. So let's say you're a studious, involved MIPS participant, and you've worked really hard and you've gotten 25 out of 30 quality points, which in this day and age can be pretty hard to do. In addition, you've gotten a perfect PI score, you've gotten a perfect IA score. So at that point, you have 65 points. If you get an average cost score, you're at 80. So despite the fact that you worked really hard to get those other categories nearly perfect, you're only 5 points above the threshold. So many people are saying, okay, talk to me about cost, talk to me about what I can do to get that score up, because there's 20 more points left on the table there. So that's why we're here to talk today, to understand cost, to understand the cost measures, and see what can be done to work on improving both performance and scoring. At this point, I'm going to turn it over to Daniel, and he's going to talk about the actual measures.
Switch mics. Hello. My name's Daniel Patrick, and sorry about that. I'm going to start off talking about the cost measures for 2024. So right now there are 29 cost measures, and the most popular of which is the TPCC measure. This is the one that's attributed the most, and then Medicare spending per beneficiary, or we call it MSPBC. So these are the most attributed to measures. Total per capita cost is about looking at a patient over a full reporting year. This measure has been updated to reflect some changing relationships between a patient and a provider. So it used to be that if you saw a patient during a year, you would be attributed that patient for the entire year. And now you'll be attributed for basically 12 months, but they don't have to be the exact 12 months of a calendar year. So if there's a patient that goes away from your practice sometime during the year, you won't necessarily be attributed all the costs for the entire period where you might not be seeing that patient. The MSPB measure is focused on an inpatient stay. So some kind of hospital event occurs and they look at the costs surrounding that event and basically focus on the treatments that are done around the specific inpatient event and then the costs in like about a 30-day window around that period. So any related visits or similar services that are done can all be included there. So then we have procedural episode-based measures. These are focused more on a specific procedure. So those will be, all of the rest of these basically are more attributed to specific types of practices. At least the procedural and then acute inpatient medical condition, those are typically high cost procedures that are done in a specialized environment. And then the chronic condition measures and the emergency care measure are newer ones. Those focus on, obviously chronic is about depression, lower back pain, and things that can affect a patient over a long period of time. And then the emergency department is focused on a single occurrence of an ED visit. Next slide, please. So here's a chart that we mocked up to show the attribution from the claims that we've looked at. So you can see here 50% of our users have one measure attributed, and then it decreases down there, and you see very few with more than 9, which makes sense. And a lot of those are the TPCC measure, followed by the MSPB, and then the diabetes, which is a chronic condition, as asthma is also a chronic condition, and then the others there are more procedural. And then anything that's not shown here is under 1.5%. That's, yeah, you can go ahead. Thanks. So here's a list of all the measures. You can just take a quick look at this, and this is available elsewhere if you have any questions about what measures you might be attributed. These are the ones currently, this is the full list of everything. So anything that can be on here, you saw the attribution as typically only a few of these and not too many for a single practice. Next slide. So scoring here, you can see the traditional MIPS is the general way that you'd be attributed. This is what we showed out of the 30 points, and you could have any measures attributed based on what procedures CMS finds within your claims, versus if you take the MVP route, then your specific MVP will determine which cost measures can be attributed. So this is a way to possibly avoid measures where you might not score as high. And then for APP, there is no cost score. Do you want this one? Basically, for an MVP, CMS calculates data only on the measures that are included in the MVP that you've chosen. So you could have other measures that would normally be attributed, but you'll be exempt from those if you've chosen a different MVP. So you can see based on the chosen MVP here on the left of this chart, which measures could possibly be attributed. So basically, if you are in the advancing rheumatology MVP, you would not see any measures other than TPCC reflected in your score. And then here's a continuation of those. You can see a lot of them have TPCC or MSPB. As I said, those are the most common. And then some of these more specialty MVPs will only have a more specific measure.
So I'm going to talk a little bit about how these measures are attributed and calculated. This is really technical stuff, so bear with me. Sometimes I question why we go through this with folks, but I think it's important to understand a little bit of the background, a little bit of what all's going on behind the scenes, so that you can react appropriately, both in terms of understanding and then thinking about how you might be able to drive better costs going forward. So every single measure goes through these six steps. And every single measure goes through these 6 steps differently. Um, Basically, what we do is we look at all of the data, all of the claims data. You can see me holding out my hands here. All of the claims data that CMS gathers, and they trigger an event based on either an episode starting or an encounter with a patient. And then they run through this whole process. So I'm going to walk you through this process pretty quickly. If you have questions, let me know. But it is a little bit technical. So Mike, next slide, please. So step one is to trigger an episode. Each measure is composed of, so each measure has episodes that are accumulated for it. And an episode is triggered by some sort of relationship between a clinician and a patient. So here what I've done is I've shown for TPCC specifically, which again, to Daniel's point, is probably it is the most attributed measure. It is a measure that is difficult to understand the total cost for, because costs are coming in from lots of different places. But for each TPCC episode, what happens is CMS looks for a candidate event. That is 2 things happening within either an individual clinician or a clinician group. So if you have what's called a primary care E&M service, and you have any of a myriad of services that are listed in a CMS list, which is available on our website, those 2 things occurring within 90 days, or another clinician billing within 3 days, then you trigger a TPCC episode. That means that for the next year, you're going to have that patient's costs attributed to you. That's the trigger for TPCC. If you're looking at an acute episode, it's probably feels a little more logical in that it's, did I bill a hip surgery? Did the patient go into the hospital for sepsis? Did the patient go into the ED? There are a lot of very cut and dry, this is how an episode's triggered. In the case of TPCC, it's a little more nuanced with this. Also, if you are I'll talk about that later. Next slide. So once the episode is triggered, we define the period of the episode. In the case of TPCC, as Daniel said, it's basically a year long. So it starts from whenever that initial encounter happened, and it goes for a year. Now, in this case, what we're showing is, let's say that initial office visit happened at the end of January, and the and the virus vaccine happened also in January or February. That episode is going to run through the following end of January of the following year. And CMS chunks out all of that data into what they call beneficiary months, which are 4-week windows. Each measure has a different length of an episode. In this particular case, it's always a year. Some of them start 90 days prior to the trigger. Some of them start on the day of the trigger. Some of them end after a certain number of days. Some of them end after a discharge from a hospital. And some can last, mainly the chronic conditions, can last up to 2 years. Next slide. Then what we do once we have episodes is we attribute them to clinicians. In the case of TPCC, we attribute based on that E&M service that's billed. In the case of MSPB, it's attributed either based on the actual procedure, if it's a surgical procedure, or clinicians providing at least 30% of the E&M services. In the case of acute care, it's again 30% of the inpatient E&M claims. So you can see there's various ways that these get attributed. Again, if you're interested in more information on any given one, you can either look up the spec on the CMS site or you can contact us. Next slide. So again, what we do here is we look at, for this particular event, I have these 2 services that were billed. So this is going to get attributed to the clinician for a full year. Next slide. Step 3 is to calculate the cost of services. So in the case of TPCC, basically all costs occurring during the covered months, during the beneficiary months, both inside and outside of your TIN, are going to be attributed to that episode. For other measures, there are lists of specific services that are included and or are excluded. Next slide. So in this particular case, what I've shown here is I have those 2 initial trigger events, but then you can see the services on the top, the services that are kind of in teal, are those that are billed by this particular clinician. The ones in light blue below are billed outside of this clinician, but those are all going to be encompassed in this episode of care. So the attributed clinician is going to get all of these costs attributed. Next slide. The next steps are to sometimes exclude episodes and then to risk adjust the episodes. So 2 things are happening here. If we take like the top percentage of episodes and the bottom percentage of episodes, and we exclude those because those are extreme cases. We also stratify the episodes into subgroups. So for example, if we're looking at a knee replacement, is it a full knee replacement or is it a partial knee replacement? Because those have different levels of risk and different levels of cost. Then we estimate the expected cost based on the factors around the patient and the circumstances, and we apply specialty adjustments as well. So there's a lot of risk adjustment and exclusion that's occurring within these episodes. Next step. So in this particular case, in the case of TPCC, we look at every 4 weeks as what we call a beneficiary month. And we take those and we compute a risk score based on all of the factors that we see about that patient and about their care. So in this particular case, when we look at this patient, when they first were attributed this episode, their risk score was about a 1.2. And that risk score stayed pretty consistent during the first 4 months. But then they had an outpatient visit. They were probably diagnosed with some additional code, so their risk score went up. And then they had an inpatient stay, and the same thing happened, where we found that they had another condition, and again, their risk score rose. So what happens here is CMS goes through and they compute these risk scores every 4 weeks based on what they see in the past, and then they apply those risk scores to that patient to help determine the final episode cost. Confusing, right? Next slide. So then what we do to further confuse it is we take all of those episodes and we determine an average cost per episode or per beneficiary. And I'm not going to run you through this math here, but Here at Healthmonics, what we've done is we spent the last few years examining this and replicating a lot of this logic in our application. So we do understand it. We have run through it. There's a lot of nuance within this, and I'm not going to run through all the specifics with you. But then we have the final cost of a measure. And what I'm going to do is I'm going to turn it over to Daniel, and he's going to talk about how we score each measure within the cost category then.
Thank you. So benchmarks are a very important aspect of scoring that we use several different ways. Basically, for each measure, we establish a national benchmark, which means that we're taking costs for providers all across the country and finding a set average of that expected cost for their episodes. Well, sorry, I mean that they're the actual cost, because expected cost is a different thing that we also use. But this determines the average expected cost, which is about the middle of the road for your cost score. No historical benchmarks. That I think is a quality aspect that doesn't apply here. So you can see for each one of these measures, we have an average performance rate for 2022. Next slide. So we use those benchmarks to create the deciles, and this is how we determine where your score will fall from 1 to 10. So we're taking this average benchmark, and then we are averaging all of a practice's costs for each of their episodes, and then finding through risk adjustment, we can compare that to the benchmark and then determine where it falls in one of these ranges. Next slide, please. So a lower cost equals higher score. This part can take a little bit to get used to, but you can see at decile 1, it means that you would get 1 point, which means that you have a higher cost. Decile 10 means you would get 10 points, so you would have the lowest cost. So you can see based on this, if I had $27,000 as my average cost, I would have a 2.3. And if I had $22,000, I would get a 9.28, because that's where I'd fall in these ranges. Next slide. So the different cases for any particular practice, if you are scored on one measure, then the score on that one measure, it will be out of 10, but that will be adjusted to fit the maximum, your score out of the maximum 30 points for the cost category. So if I have one measure and I get a 10 on that measure, I am getting a 30. But if I have a 5 on the measure, then I'm getting a 15 out of 30. So everything is converted from their 10-point scale into the 30-point overall MIPS score. If I have multiple measures, then my possible score can be higher. So 2 measures, I would have up to 20 points, 3 measures, I would have up to 30, and so on. So then all of your scores for each attributed measure are added together, and then that's taken out of the potential points, which is 10 for each measure, and then that will determine your MIPS score out of 30. If there are no measures attributed, then the cost is reweighted to 0, it's removed from your MIPS score overall. Next slide. So this is what our main screen looks like within MIPS Cost Analytics. Healthmonics is a proprietary program that determines estimated cost scores for our users. So on this page, you can see the benchmark for each measure, as well as your score and how many episodes would be attributed, whether that measure would be scored or not for your practice, and then your point total.
Can you talk for a minute, Daniel, about the case minimums? Because I see that some of these have points and some of them don't.
Yes, so you can see under the measure type, there are several different types, which we've gone over a little bit, and each one of those has a different case minimum. So for like I believe for TPCC, you would need 20 patients. And then for like a procedural measure, you would need to have 10 episodes. So you can see at the bottom here, we have several procedural measures, and those don't have 10 under their number of eligible cases. So those are not going to be included in the score because there's not enough information to determine a relevant cost score. So you would be exempt from those, and they won't factor in. So that's why if you look at this in our system, we won't show any potential points or a decile score. And then we don't list them here, but there are some measures that have 20, some measures have a 35, and each one is looked at independently to see if you have the correct number of episodes to warrant eligibility. Next slide. So here's an example. If I had, out of 150 points, I had 95.7, then I would get a 64%. So then we look at that 64% out of our total 30 for our full MIPS score, and 64% from the 30 is 19.2 out of 30.
That's a lot of math.
Yes. If the more measures you have, the more complicated it gets. But as we saw from our chart before, most practices are not going to have as many measures as we're showing here. Next slide, thank you. So here is the score distribution for 2022. You can see here 20% have a 0 to 3, and then 25% have a 15 to 18. So you can see where different weights fall here. The one thing to point out is that some clinicians who are exempt from cost are possibly also in this 0 to 3 range. So getting a 0 for those people means that they got a 0 out of 0 and not a 0 out of 30. But there are also some clinicians getting a 0 out of 30. But you can see, sort of where these distributions fall. So, next slide. So now we're going to talk about ways where you can potentially affect your cost score and make some changes in order to see improvement. So the main thing from looking at your data right now in our system, it gives you the ability to look at outliers, which is a major way to understand where things might be going wrong or might be a little more uncontrolled than they seem. So for example, we can look at the highest and lowest cost providers or the highest and lowest cost patients. We can look at providers who are not involved in your specific TIN and see what kind of costs are coming from those other providers. We can look at which providers and patients have a certain number of different kinds of services. And then we can look at patients who may not be receiving the appropriate care, or patients who have an abnormal risk score. So this is a big one for us, where we see patients who, when you look at their risk score, it will tell you that this is a very healthy patient. And then when you look at the treatments being done, it tells a different story. So our system is very valuable in assisting you in finding those kind of stories where you can see that this patient obviously needs a lot of care and they're receiving a lot of care, but what CMS is believing is that this patient is actually very healthy and shouldn't need that care. And that's going to really hurt your cost score. Next slide. So I think we talked about this a little bit. We can move on. So here's our TPCC measure as an example. You can see all the providers for this practice. You can sort these by how many patients they've seen or their average costs. So this is going to give you a lot of the most direct insight, I guess, into where each one of these providers falls in terms of the benchmarks and how each of their costs are being divided. So from this page, you'd be able to see high and low cost. And then we'll move on to the patients. Here is a similar thing. You're able to sort on any information you see here. So we can look at who was attributed for the most months out of the year, who may have received a lot of services compared to another patient, and then again, finding the outlying costs. We can see some examples here of this Calvin Manning with 398 TIN attributed or TIN provided costs, and then $92,000 in overall costs. So this overall cost you're seeing is what you would be attributed for this measure. Next slide, please. So once we go into a specific patient, we can see for the TPCC measure in particular, what their risk scores and costs look like across the year. So here we can see that this patient started off with relatively low risk. They had somewhere between 1 and 2, looks like on the lower side of that. And then I guess the first thing to point out is that you can see 13 months here. These aren't divided by calendar months. They're 4-week increments to make them all even. So we use numbers there instead of month names because they're slightly misaligned from that. So we can see here from month 8 to month 9, there was a massive increase in the risk score. At the bottom here, we can see all of their different claim types broken down with the cost for each one, as well as the total to see where most of their costs are coming from. You can see a lot of carrier claims. And then from here, we can drill down into specific claim types. On the next slide. So when I look at all claims for this patient, I'm seeing, again, every claim type, as well as the risk score associated with that beneficiary month, and then a description of what services were provided in that claim, and the date of performance, and the standardized lot amount for that cost. So I think, do we want to talk here about this specific case with what we see here from month?
Sure.
So we saw on that chart, and you can see it reflected here as well, that the risk score from month 7 to 8 goes down a little bit, and then in month 9 it goes way up. And I believe they had a diagnosis of hypoxemia in month 8. So we see that as something that could have that large of an effect on their risk score. And now with that higher score, that's going to adjust the cost in a different way. In this case, your expected cost will be higher for a higher risk patient. So your score will be a little more forgiving for patients with a score like a 6.5. Next slide. So from what you've seen there, this should be a little clearer. Here are some ideas for what we can do to affect scores using this system. So understanding costs attributed to your patients, we saw how we can go into each claim type, each claim for each patient and provider, and really see where every cost is coming from. And then we can find those variations by sorting and finding the outliers in any category of physician or patient. And then this also allows you to take another look at how the risk coding is going for HCC and see, like we just showed, how a patient's risk can be affected from month to month. So another thing we can do is looking at sorry, can you go back? We can look at the specialists and referrals from different claims and see patterns in where high cost claims might be coming from, and make more educated decisions about referrals in the future. And then look at the costliest patients and determine what could be done about those in particular, and find patients who may be getting misattributed or just could use a slightly different care based on what we're seeing in trends in their data. This also will let you look at your potential cost scores and decide if you want to participate in an MVP that could limit your vulnerability with certain types of measures. That's all for that slide. So again, with our software, we can look at the cost score throughout the year. We gather data several times throughout the year. The data you'll see in our system is about 6 months behind the current time period, the current month. And we annualize those scores to estimate what your cost would look like if you continued in a similar way. So you can get an early idea of what to look for there. We can do some of the actions we talked about there to affect the scores for each measure, and then see which patients and physicians are being scored in a good or bad way. We get visibility into how HCC scores are being calculated for each patient, and finding the outliers of patients and providers to find the lowest effort ways to have a large impact on your score.
So this is Lauren again. So at the beginning of our discussion, I talked about how CMS is really scoring folks on items that there's little visibility into. And so what we've tried to do is to give you more visibility into your data so that you can look at providers and see which providers are doing better, which providers maybe have some room for improvement, to look at patients, to look at various referral patterns and scoring and coding and all the various things that really do affect your cost score. Because we realize that we work so hard on the quality side. We want to allow clinicians to also work on their cost score, so they're not just, I'm going to use the term, saddled at the end of the year with a score that they can do nothing about. So we're trying to help folks dig into their scores. We can certainly do it through this product. There's also some data that you can get from CMS. At the end of the year, they do share some attribution information through your HARP portal. We're happy to help you look at that data as well. But what we're really trying to do here is help everybody, A, understand the cost category, and then B, work on upping the care and hopefully the score that they're giving. And then B, and then C, I think that at some point this cost information is very valuable as you think about moving into perhaps advanced payment models. So if you can start capturing, in particular, a lot of that information around the TPCC measure and the MSPB measure, and even some of your specialty scores, if you're a specialist, you can use that data to then go show other referral, either recipients or people that are referring to you, some of your scores and help kind of validate the quality and cost of the care that you're giving. So at that point, I'm going to open it up for questions. I don't know, we've tried to answer a few of them online, but if anybody has any specific questions, please type them into the chat box now, and feel free to reach out to us. This is new to everybody. We welcome discussion around it. You can reach out to Mike and his team, and we'd be delighted to talk with you. Somebody asked about pricing. I think our sales team can help you with that. And beyond that, I don't know that I see any other questions in the chat. Daniel, do you?
There's, yeah, none right now that,
All right, looks great. Thank you very much, Lauren and Daniel. Everybody, I will be sending out this presentation and recording as well as the slides in a little bit. If you have any questions, you can always reach out to me. We are available to help you decide what you kind of need to do and tell you where we can help you. Daniel and Lauren, thank you very much today, and talk to everybody soon.
Thanks all. Take care. Bye-bye.